Thank you all. Thank you, organizers, for this wonderful opportunity. Can you see my slides, please?
Yes, we can see it.
So I'm tasked with the review of best abstract from the ASCO GU 2022 with respect to prostate cancers. I have selected out 3 abstracts actually, and 2 of them have already been discussed by Dr. Abhishek Anand, but let me go through the slides. So this is the PROPEL study, which was done in the metastatic CRPC. As we all know, the overall survival and survival endpoints for metastatic CRPC in the clinical trial setting is around 3 years. And in the real world setting, only about 50% of the patients can actually take more than 1 line of treatment. And with that 1 line of treatment, the overall survival is around 2 years. So there is real need to identify the first line treatment strategy, newer treatment strategies. Herein we have the olaparib in combination with abiraterone tested as a first-line therapy for patients in the first-line metastatic CRPC setting. So as we see, it's a global randomized double-blind phase 3 trial. These are the patients who are taking the first-line metastatic CRPC systemic treatments. No prior abiraterone was allowed. However, docetaxel can be given to these patients, especially if they have taken during the hormone-sensitive phase of metastatic prostate cancer. These are all good preserved patients with good performance status and very minimal symptoms with ongoing androgen deprivation therapy. These are patients randomized in a 1:1 fashion to the experimental group of olaparib full dose at 300 mg twice daily, abiraterone 100 mg once daily versus placebo and abiraterone. And the results were stratified based upon the site of metastasis, prior taxane use, yes or no. Coming to the primary endpoint, this is the radiographic progression-free survival. The key secondary endpoints are overall survival, also the time to first subsequent treatment or death, time to second progression, which is basically PFS2, objective response rates, safety and tolerability, and quality of life concerns. So if you look at the study disposition, there are nearly 800 patients which are randomized to the cohorts, experimental and the control groups. The baseline characteristic between 2 arms are very well balanced. Coming to the planned interim analysis, the first-line treatment with olaparib and abiraterone definitely improved radiographic progression-free survival compared to that of placebo and abiraterone, with a PFS of nearly 2 years, 24.8 months versus 16.6 months. This benefit was irrespective of the HRR status. HRR status was not a prerequisite for the study enrollment. If you look at the landmark survival analysis at 2 years, we can see that 2-year PFS was around 51.4% versus 33.6% in the favor of the experimental group. Hazard ratio of 0.6, which is statistically significant. The overall survival is not yet mature yet. There are around 30% events that are recorded. However, the early trends are showing that the overall survival might be better in the experimental group of olaparib plus abiraterone. Moving ahead with the subgroup analysis, these are the predefined subgroup analysis. We can see that PFS was better across the different subgroups in the experimental group, especially even the presence or absence of HRR mutation status didn't matter. However, the hazard ratio was better in the HRR mutations patients at 0.50, but at 0.76, it was also statistically significant in those patients without HRR mutations. So this is the key secondary endpoints of overall response rates. The use of the experimental group definitely improved overall response rate by nearly 10%, 58.4% versus 48.1%. Coming to the key safety and tolerability issues, the most common grade 3 adverse effect was anemia, which was seen in 15.1% in the experimental group compared to 3.3% in the control group. The olaparib discontinuation was seen in nearly 14% compared to only 8% in the placebo group. Coming to the abiraterone discontinuation, it was similar in the both groups at around 8.5 to 8.8%. Coming to the other key adverse effects, which are cardiovascular and thromboembolic events, there was numerically higher thromboembolic events in the experimental group. However, these are asymptomatic and only image findings. This did not lead to the discontinuation of the study group. Coming to the quality of life issues, the quality of life as assessed by the PACT-P questionnaire was also compared between the treatment arms. Coming to the take-home messages, in the interim analysis, the PROPEL met its primary objective of improved PFS compared to that of the abiraterone plus placebo. This benefit was seen irrespective of the HRR mutation status, and this benefit led to a median PFS of beyond 2 years. It has a safety profile that was consistent with the known safety profiles of the individual drugs, and this benefit was demonstrated irrespective of the need of HRR stratifications. We need to look at the overall survival analysis to make a sense about what this formulation is going to bring into the standard of care. Let's move into the second trial, which is ARASENS trial. This looks into the newer darolutamide in combination with docetaxel. So if you look at the triplet drug combination, this is not new. We had a Peace-1 clinical trial that tested the utility of abiraterone in combination with docetaxel in combination with ADT in the metastatic hormone-sensitive prostate cancer. There were several benefits which were demonstrated in that trial. Also, in the enzalutamide trial, the enzalutamide combination with docetaxel was seen in some subgroup of patients, and there also there was a benefit with respect to overall response rates and survival. And here we have the newer darolutamide that again was tested in the metastatic hormone-sensitive prostate cancer patients. These are the patients who are basically candidates for chemotherapy, and they have been randomized in 1:1 fashion to either placebo plus docetaxel or darolutamide plus docetaxel. The primary endpoint of the study was overall survival. The key secondary endpoints were time to CRPC, time to pain progression, and skeletal event free survival, and time to first skeletal cell event. And also there is safety data also. So nearly 1,300 patients were randomized between November 2016 to June 2018. The study population closely matched the clinic population because the median age is nearly around 70 years, at 67 years. If you look at the primary analysis, at the primary data cutoff point of October 25, 2021, the authors observed a significant, that is 32.5% decrease in the risk of death among those patients who have taken darolutamide compared to those patients with placebo and docetaxel. So at the end of 2 years, the overall survival rate was 50.4% versus 62.7% in the favor of the use of darolutamide in combination with docetaxel, with hazard ratio of 0.68. Coming to the additionally, this effect was consistent across all pre-specified subgroups, and with consistent effect, there was no major benefit with particular subgroup or particular Gleason score or site of metastasis. Again, the overall survival with darolutamide versus placebo in combination with ADT and docetaxel, we can see the key secondary endpoints of time to CRPC, time to pain progression, time to first skeletal event. All these are in favor of using darolutamide in combination with docetaxel. Coming to the safety data, in terms of safety, surprisingly, the authors have found similar rates of treatment emergent adverse effects. The most common were highest during the overlapping docetaxel treatment periods. Nearly 66% in the darolutamide group and 63% in the placebo groups had grade 3 effects. Most of them were neutropenic at 33% versus 34%. Finally, we come to the PRECIDE trial, which is a randomized double-blind placebo-controlled phase 3B study that is studying the efficacy and safety of continuing enzalutamide in those patients with chemotherapy-naive metastatic CRPC who are being treated with docetaxel prednisolone and have been progressed on enzalutamide. Basically, in the hypothesis of the study is that in those patients with metastatic CRPC, those who are progressed on enzalutamide, continuing the enzalutamide may actually benefit those metastatic clones which are still responsive to the androgen deprivation, and docetaxel can take care of those clones which have the accessory pathways for progression. So this is the study schema. It is initial period 1 is an open label enzalutamide phase in which patients are offered the enzalutamide, and at the time of disease progression, patients are randomized in 1:1 fashion to either placebo plus docetaxel or enzalutamide plus docetaxel, and the primary endpoint of the study was PFS. So this is the study disposition. Out of the 800 odd patients were screened, around 600 odd patients were treated with enzalutamide. Of these, 392 patients were actually having the disease progression. 271 was treated, out of which few patients were given enzalutamide, 136 patients were given enzalutamide plus docetaxel, and 135 patients were given placebo plus docetaxel. So again, this is the study disposition. As you can see, most of the study characteristics are similarly matched between the two arms. This is the primary endpoint of PFS. The addition of enzalutamide to docetaxel definitely improved PFS with a hazard ratio of 0.72, resulting in an improvement of 1.3 months in the median PFS. And the PFS benefit was seen subsequently in most of the subgroups. If you look at the the forest group, those patients who are having visceral metastasis and those patients who are having bone and tissue disease are having more benefit compared to those patients who are having bone-only disease. So maybe the combination of enzalutamide combination with docetaxel or post-enzalutamide progression may benefit those patients who are having a significant higher disease burden compared to those patients with only bone-only metastasis. Coming to the secondary endpoint of time to PSA progression, again, compared to a placebo, enzalutamide definitely improved time to PSA progression and also resulted in a greater mean decrease in the PSA levels from the baseline. And the overall response rates were also better at 32% versus 26%, and also complete responses are marginally better at 19% versus 13%. Again, coming to the safety, we have seen that enzalutamide in combination with docetaxel being very toxic. This has been shown in the Enzamet trial as well. There was a cohort of patient who was taken in the first-line metastatic metastatic hormone-sensitive setting, that the combination of enzalutamide with docetaxel increased the toxicity. Again, we look at the all treatment adverse effect, it was similar, but the serious toxicity was 49%, nearly 50% versus 40%. Again, the deaths were nearly 10% versus 5%. So in spite this combination showing benefit in terms of PFS and also time to PSA progression, there appears to be safety and tolerability concerns. Maybe we should be using this drug only in those patients who are fit. So that will conclude my review of some of the abstracts which are presented in the ASCO 2022. Thank you very much.